So good afternoon, everyone. We have PRK as we had discussed last time. There were a lot of hands for PRK, or I am sure that today's class will be very useful. I was telling you in the last class also that Dr. Pravin, he had undergone PRK himself for his own eyes, and this means that it's not that it's PRK. I'm sure that all those will be answered today. और आई होप दैट सब लोग इस पर्टिकुलर क्लासेस को एंजॉय कर रहे हैं एंड एवरीबॉडी इज गेटिंग बेनिफिटेड आल्सो इट्स ग्रेट टू सी all of you here again. कोई कुछ anybody can do you want to say anything by the time Dr. Pravin is joining? आप Darshana, they can raise hand, no?
They can raise hand as well, and they can write something in the chat box if they want to convey something to us.
Okay, so I have also opened my chat box here. Great. So we'll keep on writing questions, whatever questions come, and we'll keep on answering them. वैसे मैं आपको बताता हूँ PRK per se. I have been doing PRK for the last, I think, close to 9. Oh, Dr. Pravin is around. Hi, Pravin. Welcome. Darshana, Pravin.
Yes, sir. I have unmuted, sir.
Yes.
Good afternoon.
Yeah.
Hi, Pravin. Welcome, and so great to see you again in this group.
Hey, hi, Vikas. Thanks again, and thanks to everyone for staying up in the afternoon to be here. Really nice to see that all of us actually are looking for information other than the coronavirus.
Yes, exactly. So this makes our focus on something constructive and something positive. And thank you so much for giving your time. And we were just discussing how good or bad the PRK is, and everybody is looking forward to hearing for you. For those who were not there in the last class of Pravin is a refractive surgery also, and he has a tremendous experience and a very good knowledge about refractive surgery. We had heard about how to decipher topography from him in the last class, which was amazing. And even Pravin, I just want to tell you that we have put that class on YouTube, and a lot of people saw that and sent very good comments on that. And I'm sure that today's class will also be very informative. It's 3 p.m. So over to you, Pravin.
Thanks, Vikas. I'm going to start sharing my screen right now. So while I do that, again, some of you will probably notice that Vikas is not wearing glasses today. So, all right. So we'll start. Sorry?
That's because I'm press biopic now.
Yeah. Well, thanks again, and welcome to this hopefully useful lecture. This webinar, what I'm going to do is I'm going to focus on surface ablation, and hopefully by the end of maybe 45 minutes or so, I'm hoping that I would have convinced you that surface ablation is actually a good thing and is not inferior to several of the procedures that we're used to hearing about right now. So the sequence of what I'm going to speak about today, we'll do a brief introduction into refractive surgery and also laser ablation. Then we'll talk a little bit about the different types of surface ablation, and then we'll spend some time looking at the benefits of doing PRK over LASIK and the potential issues with LASIK in the future. Then very briefly about the new kid on the block that everybody's been talking about, the topo-guided PRK, and where it has a role and what kind of patients are really suitable for topo-guided PRK. Then a little bit about PRK for high myopia and what kind of cases are suitable to do PRK as well. And then finally, very brief segment about transepithelial PRK, because that is something that everybody seems to be talking about and seems to be saying that this is better than regular PRK. So this might be a bit of a repeat for several of you who have been doing refractive surgery, but I just thought that for the youngsters in the group, it's nice to look at the evolution of refractive surgery from the time that people started thinking about correcting refractive errors. So all of you would have heard about RK or radial keratotomy. This is something that became popular in the mid-1970s and later on in the 1980s as well. This was sort of replaced by PRK partially when PRK came in, because PRK was something that became popular in the late 1980s, though RK continued in the 1990s and sometimes in the 2000s as well. Following PRK, LASIK became popularized by Palicaris again in the 1990s, but was only widely adopted in the early 2000s. And then after that, you saw that SMILE became a surgery that was the next generation apparently after LASIK. Now, when I speak about these kind of evolution of surgery, it does not mean that each surgery is better than the previous one. Except in the case of RK, all three, PRK, LASIK, and SMILE, are done quite frequently by surgeons. And there are advantages and disadvantages to each of these. So it doesn't mean that SMILE is better than LASIK or LASIK is better than PRK. But then the reason why it's important to look at this evolution is because with time, people have tried to make surgeries safer and more predictable, and also with a greater accuracy from the point of view of the outcome. Also, if you look at refractive surgery actually, to become successful, it needs to be a procedure that is easily accessible to a lot of people. Should be done by moderately skilled surgeons. You can't have a highly complex surgery like a retina surgery, which will become successful as a refractive surgery. It should have a short learning curve, and also the results should be relatively reproducible. Otherwise, most people would not like to do this kind of surgery. So what are the options that we have right now? Amongst the options for refractive surgery, they can be divided mainly into three categories. Surgeries that include any incision on the cornea. These are called incisional surgeries. Then you have surgeries that are called ablative surgeries, or surgeries where you use a laser to remove part of the corneal tissue. And then you have implant-based surgeries. So you have implant-based surgeries where you put in an implant inside the eye, like an Intacs or maybe a phakic IOL. There are some surgeries that don't fall into any of these categories. For example, SMILE really doesn't fall into any of these because it is not an ablative surgery. So you could create another category called others. But for today, we're going to focus mainly on ablative surgery, which is by far the most frequently performed surgery amongst refractive surgery at this point of time in the world. So before again we talk about the specifics of LASIK or PRK, how does myopic LASIK or PRK work? Well, in college, where I was going through my residency in ophthalmology, we never got to see a refractive surgery. So the belief then was the fact that refractive surgery or LASIK or PRK works by thinning the cornea, by making the cornea thinner than what it was. Well, it's only partially true that that's a side effect, but that's not the reason why it works or how it works. Refractive surgery or LASIK or PRK really works by changing the contour of the cornea and actually flattening the surface of the cornea in case of a myopic correction. So that is how LASIK or PRK really works. So if you also look at the evolution of ablative refractive surgery, though we went through the brief evolution of refractive surgery, PRK probably was the one that became popular earliest in 1980s, then followed by LASIK as we saw earlier. And this gave rise to customized LASIK, where people started to measure aberrations from individuals' eyes and then went on to do surgery. Finally, this transition into femtosecond customized LASIK and followed by something called advanced surface ablation, which are nothing but new avatars of LASIK and PRK. So I hope this cartoon plays and you're able to see this, but this is basically a very small cartoon that just shows the method of performing PRK. PRK is done by removing the epithelium by any method that you would like. You can use a brush, you can use alcohol, and then using a laser to correct the surface curvature of the cornea. Once that is done, then you either use Mitomycin C or you don't, depending on the refractive power of the eye, and you finish off by putting a bandage contact lens on the eye of the patient. So very simply, that is how PRK works. And the reason why PRK for several years did not become popular or gave rise to LASIK is because in the days when PRK was really popular, the kind of lasers that were used to do PRK were broad beam lasers. And these lasers used to cause a lot of haze, as you can see in the picture right here. And haze also led to regression, and thus PRK fell into disrepute. And it still seems not to have recovered from the position that LASIK holds right now. So PRK or any of these surgeries fall into the category of surface ablation. There are three major surgeries in surface ablation or advanced surface ablation. You have LASIK, you have PRK, and you have epi-LASIK. All three of these surgeries, the surgical technique is slightly different. We can discuss that later if you want to, but we're not going to discuss that right now. But just remember that at the end of the day, there is absolutely no difference between the outcomes of LASIK or PRK or epi-LASIK. It's just another way of doing surgery. And the reason why some surgeons propagate LASIK or epi-LASIK is because it sounds like LASIK. So they believe that more patients will actually like this surgery as compared to PRK that doesn't sound like LASIK. So if you actually look at the eventual outcomes, there is no difference in the accuracy of correction, no difference in the visual acuity. There have been some publications about pain being lesser with LASIK or epi-LASIK, but we've not seen that. And in fact, there is no difference in the amount of haze as well. So that was about an introduction to surface ablation. So going on to the next stage of what we're going to be talking about, let's briefly talk about what is the difference between surface ablation and LASIK and how they differ from the perspective of their outcomes. So traditionally, surface ablation is used in patients who have relative dry eyes, or maybe a poor ocular surface, or maybe somebody with an anterior stromal scar in the cornea, or maybe somebody whose profession dictates it, like somebody from the armed forces or somebody who's going to the police who doesn't want a scar on their cornea. Sometimes surface ablation is a better procedure for them. They don't want a flap. And in cases where flap creation may be an issue, you might want to use surface ablation. And also in cases where you prefer to avoid suction on the cornea, like say somebody has had a retinal issue, you do not want to apply suction on the cornea. There are some cases of patients you probably wouldn't be doing surgery anyways, but glaucoma surgeons generally feel happier if you do PRK on them as compared to LASIK surgery. So briefly, I want to take you back a little bit in time and show you the topography of a patient who was operated for LASIK in 2002. If you look at the timestamp right at the top, you'll see that the timestamp shows that this patient underwent surgery in November 2002. And if you look at the topography, especially from the class that we had last time, you'll see that the topography looks relatively normal. It does not look completely abnormal. Nice green color, nice flat blue color. The thinnest point of the cornea is shifted out slightly. It is slightly thinner than what you would prefer. But in 2002, the criteria were different. It's about 18 years ago. But typically, you'll see that the topography was not abnormal. So after this patient underwent LASIK surgery for a -3 refractive error, and also with a residual stromal bed of more than 300 microns, this patient came back 5 years later, and you'll see that this patient had signs of inferior ectasia, that little yellow dot that you can see start appearing on the bottom of the cornea. This went on to develop full-blown ectasia in 2010, and finally we had to cross-link this young lady. And then just showing you that when you are confronted with one of the most serious long-term complications of LASIK surgery, this is post-LASIK ectasia, which can occur from anywhere between 1 year after surgery to even 10, 12, 15 years after surgery as well. So we briefly spoke about why post-LASIK ectasia is a major issue. The major issue is the fact that it is probably slightly underreported because a lot of people believe that this is keratoconus, but then the fact of the matter is, if you wouldn't have done LASIK, a lot of these patients would not have developed post-LASIK ectasia. About 50% of cases only are reported within the first year, and 50% of cases occur later on in life, including what we're seeing a trend nowadays of young ladies who have LASIK surgery. And then somehow pregnancy seems to have something to do with induction of ectasia. and they develop ectasia after their pregnancy as well. Another important reason why LASIK in cases that are borderline is a little concerning is if you look at the Randleman criteria for doing refractive surgery and for people who are at risk of ectasia, you'll see that the little red box that I've highlighted here highlights the age of the patient. And the risk criteria is 0 is no risk, 1 is mild, moderate, and severe risk as you go up the scale. You'll see that people who are automatically in the age groups of 18 to 21 or 22 to 25 are in risk groups 2 or 3 by itself. And you all know that the commonest age group that we actually perform refractive surgery in India at least, is between maybe 18 and 25 years. In the West, this is different because the commonest age group or the average age for refractive surgery is about 36 years. In India, the average age is about 23 years. So that actually means that we are already operating on patients who potentially have a higher degree of risk from the perspective of developing ectasia in the future. So there are a series of publications, actually case reports, that actually talk about a patient who's undergone, this is the preoperative topography of the patient, and from last class, you'll see that it is completely normal, who underwent LASIK in one eye and developed ectasia after LASIK in that eye, but underwent PRK in the left eye for whatever reason and did not develop ectasia in the eye that underwent PRK. Now, this is not an isolated case. There are at least 5 cases that I found in literature where patients who have undergone LASIK in one eye and PRK in the second eye developed ectasia in the eye that had LASIK, but did not develop ectasia in the eye that had PRK. So what I'm trying to get at is the fact that the same patient, if you do LASIK and PRK in the 2 eyes, the risk of developing ectasia seems to be more in the eye that has undergone LASIK because of factors that we do not know. So you would probably say that what causes ectasia, so let's eliminate all those risk factors so that we know that we will get a 100% chance of not getting ectasia after LASIK surgery. But again, the sad truth is the fact that we really do not know what causes ectasia. A lot of people believe that it's biomechanics of the cornea, but there's no consistent proof. People believe that it's because of eye rubbing. That probably is true, but then again, there are a lot of people who rub their eyes who don't get ectasia as well. Possible some role of genetics in developing ectasia, and I mentioned pregnancy as one of the factors that tends to cause ectasia to progress relatively fast. So we do not even know if LASIK is the chief cause of inducing ectasia in patients like this because of the cut in the stroma. Recently, there have been some cases of post-SMILE ectasia as well, and so we know that SMILE too can cause ectasia. Whereas if we look at literature, there is almost no case of ectasia after PRK, and the only cases that are reported of ectasia after PRK are patients who had preoperatively abnormal topography that was already suggestive of keratoconus. So it seems as if it probably was a natural progression. So if you actually look at all these factors that cause potentially ectasia that we believe in right now, all of them are something that you probably cannot control, including pregnancy. So the only thing that you can control is the choice of refractive surgery. And that's the reason why, at least I believe, that from the point of view of ectasia, PRK is a safer bet than LASIK. It gets even better. So if you look at, this is a series of cases that Damien Gatnell from Paris had published several years ago, where he performed PRK in patients with suspected keratoconus and followed them up for 5 years. And then again, he found that none of these people actually developed ectasia, which again is a little surprising, but again is good news because it doesn't seem that PRK at least increases the risk of developing ectasia after surgery. The other argument that I hear a lot is the fact that, sure, PRK might be better than LASIK in the long term, but then PRK does not give as good vision as LASIK. Well, this is a meta-analysis that compares all the published literature between LASIK and PRK. And the 3 chief findings of this is the fact that though visual recovery is a little faster following LASIK than PRK, the final uncorrected visual acuity is comparable between the two, and there is no difference in the post-treatment refraction, that is the accuracy between LASIK and PRK. And this again tells you that PRK, from the point of view of vision after surgery, is as good as LASIK. So now let's take another detour and speak briefly about topo-guided PRK, or Contura as some people call it because of the brand, and whether this is something that is the next generation of laser surgery for patients. Disclaimer, we do have a machine that does Contura laser on a patient, and at this point of time, we've done several studies to compare topography guided surgery versus wavefront optimized surgery. And in normal corneas, that is people who come to you for refractive surgery, we really have not seen a major difference between the outcomes of these two surgeries. Where the difference becomes apparent is in patients who have abnormal corneas before surgery. So there are several differences between the two. We'll probably not get into that at this point of time. But then the major advantage of topo-guided LASIK or topo-guided PRK is the fact that you can correct irregular astigmatism on corneas. And this actually is part of a subgroup of patients like, say, post-keratoplasty, like you see in this picture, somebody who's undergone refractive surgery already in the past, or maybe people with keratoconus as well, combined with cross-linking. This is where topo-guided PRK actually works really well. An example of this is this topography. This is a post-refractive surgery patient, and you'll see that in the topography map on the upper left side, you'll see that there is a zone of flattening that is not exactly central to the pupil. And this means that this is a patient who has had decentered ablation. So after decentered ablation, this patient probably will not have very good visual acuity because the optic zone is passing through the pupillary area as well. Another example of somebody who's had decentered ablation, as you can see in the topography map in the bottom left corner. And if you see this patient after undergoing surface guided treatment by enlarging the optic zone, you'll see that he has a much more regular topography now. And this generally is one of the methods we use on topo-guided treatments to ensure that patients have better visual acuity in case of a patient who's had a problem with refractive surgery. Similarly, this is a patient of keratoconus. You can recognize this scan from the class that we had last time. Uncorrected vision 20 by 100, best corrected 20 by 60 with -2, -5 into 170. Now, if you do regular PRK for a patient like this, he probably will have a reduction in the refractive error, but the best corrected visual acuity will not improve very much. Instead, we did a topo-guided PRK for this patient along with cross-linking. And remember, PRK for keratoconus is only with cross-linking, and you cannot do PRK for keratoconus without cross-linking. And this is a video that shows the procedure, but again, I'm not going to go through the video because I think the transmission won't be very clear. But to give you an idea of the post-op topography, this is the post-op topography, uncorrected vision of 20 by 40, best corrected 20 by 25, with a significant improvement in the cylinder as well as reduction in the sphere. And as you'll see in this topography map, the one on the left side is the pre-op topography, the one in the center is the post-op topography, and the one on the right side is the difference map between the first one and the second one, showing you that there was a significant amount of flattening after topo-guided PRK was done as well. So why are we talking about topo-guided PRKs when we're talking about a talk whether PRK is better than LASIK? This is because topo-guided treatments basically use data from the surface of the cornea. So when you are doing a treatment of the abnormal topography, it makes a lot of sense to treat the abnormal topography on the surface as well, rather than below the surface. And this becomes very apparent in patients who have abnormal corneas. In normal corneas, again, there probably is not much difference because it probably doesn't differentiate very much from a wavefront guided treatment anyways. So the next segment of what I'd like to talk to you about maybe for the next 10 minutes or so is what are the limits of surface ablation? Typically, we are taught in medical school that surface ablation has its limits. But this is the topography of a patient who has a very high myopia, minus 11.75 with -2 at 70, improving to 20 by 40. If you look at the topography, very regular topography, and you'll see that it's quite a symmetrical bow tie. The corneal thickness is slightly on the lower side, 513, 512 in the central cornea. So would put her at borderline areas for LASIK. And if we look at the anterior chamber depth, it's 2.77. So again, she's not suitable to undergo a phakic IOL. So this patient, this is the second left eye of the patient, very similar topography, very similar findings. But we did a PRK for her, and she had significant flattening of the cornea and thinning, as you can see as well. But she was plano 20 by 20, approximately 6 months after the surgery. And now we have about 5 years follow-up of this same patient, and she's doing really well, even 5 years post-op, with no refractive error apparent in the eye. That's the right eye, and this is the left eye. Both eyes, she's had an excellent outcome. Now, the reason I showed you that is to show you that PRK can be done even for people who have very high myopia. And if we look at this chart, traditionally, the pink bar shows us the limit of PRK, and the upper limit in myopia is traditionally -6 diopters. Whereas in LASIK, we tend to go up to -10 diopters as well, which is where we start transitioning to phakic IOLs. So PRK, now you can actually stretch the limits, and we've gone up to about -14 in treatments with PRK, and we've had very good results in patients who are highly myopic for a number of reasons as well. So you'll be wondering that this probably is an isolated series that I'm talking about, but there are several publications in literature as well. For example, this one by George Alio's group, which talks about correction of -10 to -18 diopters of refractive error, comparing LASIK and PRK 10 years after surgery. So the average refractive error in this group was -12.4 in the PRK group, -12.8 in the LASIK group. And you will see that at the end of surgery, after 2 years, the number of patients who had accurate refractive correction was about the same in the PRK and the LASIK group, slightly better actually for the PRK group. And at the end of 10 years, again, it was very similar for the PRK and LASIK groups. Again, slightly better for the PRK group, which shows you that even high myopia on long-term follow-up can undergo PRK with very successful outcome. The other question about doing PRK and high myopia is what happens to the haze in the cornea. So this is a 20-year follow-up of our RCT, or a randomized controlled trial of PRK, to look at what happens to haze after a really long time. And this is the haze grading for this group of patients over time. This is 1. You'll see the top of the graph is almost 1 to 1.2. So the amount of haze that these people develop seem to peak at about 3 to 6 months, which is typically what we'll see. And at the end of 1 year, it was less than 1. At the end of 20 years, it is minuscule, undetectable. So it does not mean that haze is something that is very frequent, nor is it very severe, nor does it last for a significant period of time. So haze is not something you need to worry about with PRK. So I'm going to briefly share with you some of the results that we've been experiencing, and these are results from LVP. We've been doing PRK for myopia from about 2007. So recently, we just crossed about 11,500 cases of PRK. So significant experience of doing PRK. And all of these are with Mitomycin C. A small cohort that I'll show you is about 1,300 eyes, average age of about 25 years with a 1-year follow-up. Preoperatively, the average myopia was about -5.2. And when we look at the outcomes, you'll see that, especially the chart on the right side, 92% of patients had no change in the Snellen visual acuity before and after surgery. And this is probably the most important chart, where 93% of patients at the end of 1 year had a refractive error of 0.5 or less after PRK, and 97% of 1 or less, which is actually much better than FDA published data after LASIK as well. This is a chart that shows you the attempted versus the achieved refractive correction. And you'll see that it is a very tight chart, which shows you that the attempted versus the achieved refractive correction was very similar in all amounts of myopia after PRK surgery as well. The other important finding is the fact that at the end of 1 month, as you see this graph, whatever refractive error is there in the eye seems to be about stable and doesn't really change even at the end of 12 months, which tells you that PRK patients take about a month or so for the refraction to stabilize. Once it stabilizes, it really does not change over a significant period of time. And one of the most important and exciting graphs for me is again comparing the outcomes of PRK in myopia, which is less than 6 diopters, which is the blue graph, and myopia, which is greater than 6 diopters, which is the green graph. And you'll see that it is absolutely the same, where 82% of patients who had myopia less than 6 diopters or more than 6 diopters had a zero refractive error. Some of them had about 0.25. Very, very few had about 0.5 refractive error, which shows you that even myopia that is more than 6 diopters has an equivalent outcome after PRK as compared to myopia that is less than 6 diopters. So the obvious question that all of you will probably ask me is, why don't you do a phakic IOL in patients like this? Well, there's several answers to that. But again, if you look at the comparison between the visual outcomes between PRK and phakic IOLs in high myopia, you'll see that the uncorrected visual acuity in the top red box is just about the same between the two for the same amount of myopia in 12 months' time. And the refractive index for the same group of patients is about, refractive error after surgery is the same at 1 year after surgery. And you'll see that PRK performs as well as a phakic IOL in high myopia as well. And the reason why in some cases you choose to do PRK is because of the fact that these patients are not suitable for a phakic IOL, and the quantum of refractive correction, you don't feel comfortable with doing a LASIK in these patients. So does Haze occur? Yes, certainly Haze does occur after PRK. It's not something that we'd never see. Typically, you'll see early onset Haze, and this is what you will see at about a month or so after surgery. And this, again, does not happen in all patients, happens in about 10 to 15% of patients, but is very transient. At 1 month, you'll see this, and at the 3-month visit, it'll be completely gone. Significant Haze or late onset Haze that really requires an intervention presents like this and usually occurs after 1 year after the surgery. This is a patient who had undergone PRK elsewhere without Mitomycin C, and after he presented to us, he had a significant amount of irregular astigmatism. As you can see on the OCT, a lot of subepithelial scarring and fibrosis. But then again, this is possibly the worst possible outcome or a complication after PRK surgery. So what do we do? Well, like I said again, steroids at this point of time do not work when you have Haze that is established. So starting patients on steroids is not going to work because it's just like giving steroids for a corneal scar, which anyway is not going to work. The best method of treatment is to do a PTK or a phototherapeutic keratectomy, or you can do a mechanical debridement with a diamond burr. I prefer PTK at this point of time because it gives you more consistent results, and then use 2 minutes of 0.02% Mitomycin C. And the result, as you can see in this patient, immediately post-op who had that Haze and the OCT, you'll see that the Haze is completely gone. The only thing that you need to expect is the fact that these patients will have some residual refractive error. You might not be able to take care of that completely, but the visual acuity will go to 20/20 every single time after you remove the Haze from their corneas. And this is something that is very gratifying for the most severe complication that you will have after PRK. There are a few things to remember about surface ablation in high myopes. Typically, people, where you do PRK for high myopia, take a little longer to recover their visual acuity as compared to those who have low myopia. It seems better with slower lasers as compared to the newer generation faster lasers, because faster lasers tend to heat up the cornea more, and so you'll tend to get a little more Haze with faster lasers. The long-term stability seems to be similar to LASIK surgery and seems to be an option for patients who are not suitable for phakic IOLs. I'm not saying that all high myopes you should do PRK. Phakic IOL is probably the first choice for somebody who has myopia more than 10 diopters. But in cases where maybe there is an affordability issue, or in cases where the patients might not be suitable, surface ablation of PRK is an excellent alternative. So the last segment of what I want to talk to you today is about transepithelial PRK. And the only reason I put this up in my talk is because there are a lot of surgeons who seem to say that this is next generation PRK and is much better than the normal PRK. Well, transepithelial PRK is nothing but where you use the laser itself to remove the epithelium from the cornea. Normally, we are used to debriding the epithelium of the cornea. And the advantages that people say is that the lesser time lag between the laser to remove the epithelium on the surface versus the laser starting on the cornea. So we decided to do a small study for transepithelial PRK. And what we did was we did 38 eyes of 19 patients, and we did a randomized paired eye study. One eye underwent a PRK with an 8mm manual epithelial removal. One eye underwent a transepithelial PRK with an 8 millimeter epithelial removal zone. And we did a wavefront optimized treatment for all of them. Then we admitted these patients and we looked at the size of the epithelial defect and how fast the epithelial defect healed. The difference between the healing and the epithelial defect seemed to be not significant at all. Day 4, all patients had a healing in the epithelial defect. So no real significant difference in the healing time of the epithelial defect. And there's no difference in the pain, no difference in the haze in each of these patients. So Transepi PRK is something that you will hear a lot of people talk about. It is not better than regular PRK. It's just about the same. In fact, in low myopia, Transepi PRK probably is worse off than regular PRK because the epithelial thickness might vary and you might actually cause unexpected refractive results. So why is it that I'm talking about surface ablation that's so close to my heart right now? Is because of the fact that ectasia is something that I have seen happen in young individuals, 25 people who are less than 30, with a good chunk of their life still ahead of them. And this is something that is probably completely iatrogenic, that is caused by us in LASIK surgery. And this is something that we cannot possibly predict at this point of time. To me, ectasia is something like endophthalmitis and cataract surgery. Endophthalmitis is something that all of us dread. We do our best to prevent it and we take all precautions, but you can't say that you have a 100% success rate with zero endophthalmitis. All of us will probably have an endophthalmitis at some point of time in your career. When it will occur, why it will occur, how it occurs, we can't really tell in all cases. That's the reason why ectasia will happen after LASIK surgery. And that's why you can never predict whether it will happen now or in the future or to which patient it can happen. So remember that LASIK also causes other problems like striae, folds, epithelial growth, buttonholes, free caps, and DLK. None of these problems occur with PRK or surface ablation. And that's why it probably has a much smoother post-op recovery as compared to LASIK. It's cheaper and also is more comfortable after the first 3 days of discomfort, both for the patient and the doctor. And most of the happiest patients in the clinic seem to be the ones who underwent PRK after the first 3 days. And after that, they seem to heal really well and they seem to be very, very stable with time. So if you need any further convincing that PRK is better than LASIK, this is a picture of my cornea that I took about 2 months ago for a presentation at AIOS. I was a -9 and a -1.5 myope. About 4 years ago, I underwent PRK myself for a full correction, and this is my cornea about 2 months ago. And you'll see that there is really no haze. You'll see some dots, but that is probably just SPKs or debris in the tear film. There is absolutely no haze in the cornea. And I trust PRK so much that I would undergo the surgery myself. So thank you very much, and be happy to take any questions at this point of time.
Thank you so much, Pravin. That was a comprehensive talk and very beautifully explained. I'm sure that everyone would be very happy to hear this, and you'll be surprised that we had more than 90 people in the class right now. And I can see there are many questions. So Darshana, can you please go ahead with the questions?
Yes, sir. Thank you so much, sir, for the talk. It was brilliant, and so many of our queries have been solved. So first question is from Dr. Khushbu. She wants to know the difference between optimized and guided treatments in customized PRKs.
All right. The difference between wavefront optimized and wavefront guided is not just in PRKs, it's the same in LASIK as well. So wavefront guided treatment is where you measure the aberrations from the patient's eye and then feed that into a laser machine and then treat that on the cornea. So the first example of this was the older Bausch & Lomb machines where we used to do wavefront guided treatments, and these treatments were supposed to give superior vision. But then again, it doesn't seem to be so. Wavefront guided treatments are not so popular nowadays anymore. Whereas wavefront optimized are not customized treatments for the patient. They are exactly the same as a refractive correction for any amount of myopia on anybody's eye, except that they are optimized by the laser so that there is also additional ablation that occurs in the periphery. They're also called aspheric treatments, so that the quality of vision is slightly better than if you have in somebody where you undergo regular laser treatments. So wavefront optimized treatments do maintain the aspheric profile of the cornea, thus reducing the amount of spherical aberrations that you induce after surgery. And that's why the vision quality is supposed to be better.
Dr. Khushbu? Ma'am, you are unmuted.
Hello?
Yes, ma'am. So,
Hello?
Yeah. Yes, thank you, sir. So, sir, in wavefront guided as well as optimized treatments, normally nowadays we don't do guided treatments at all.
There are some machines that are still legacy machines from the past where guided treatments are still available. An example is like the most popular machine now seems to be the EX500 from Alcon. Earlier versions, they used to sell an aberrometer with the machine, but now across India, nobody uses their aberrometer to do the laser treatments. Because you would agree as well?
True. So I personally feel that this abrasion kind of stuff, I don't know how clinically important or significant it is. So you are absolutely right. We have never used aberrometer and they have never supplied aberrometer to us. And we are using it for the last, I think, 7-8 years or so. So we don't use this thing at all. Khushbu, you are convinced with your answer?
Yes,
or you
sir.
have another query?
No, sir, I've understood. Thank you, sir.
Great. Thank you. Darshana, you can go ahead with the next one.
thank you, sir. We have next question from Dr. Debupriya. She wants to know whether PRK can be done in EBMD or Bowman's membrane dystrophy patients.
Absolutely. In fact, it is one of the therapeutic modes of correcting. The advice would be to the fact that don't attempt to treat this as a refractive correction, though you can correct some of the refractive errors in these patients as well. If you have somebody with a recurrent epithelial erosion or maybe with EBMD, the refraction that you will achieve is probably not as accurate as a true refraction in the eye. So normally the treatment is a PTK, but then you can do a PRK with the same effect, except that you might not have as accurate a refractive correction as you would have in an eye that does not have EBMD.
Okay, sir. Thank you.
Thank you, sir. We have next question from Dr. Pravin. He wants to know what are your views regarding repeat PRK for residual or any regression of refractive error?
Yeah, I think we've done a few repeat PRKs, mainly because of the fact that it doesn't seem to be required as much as I've seen in regression after LASIK surgery. There are two scenarios here. One is doing repeat PRK after you've done a PRK in the past. The only problem there is the fact that when you try to remove the epithelium is a little more adherent than in a virgin eye. But otherwise, the accuracy of correction seems to be about the same as in LASIK. The second scenario is doing PRK on the flap. If you have somebody who's had LASIK done several years ago and you don't want to lift the flap, now this again is certainly possible. The correction should be a small quantum because you do not want to go through the flap and go to the interface. So generally, if it is less than 2 diopters, then I would do a PRK on the flap of a patient who's had LASIK in the past as well. Also, as a corollary to your question, if you have a very low myope, say minus 0.5, who insists on getting refractive surgery done, then what would be the choice of refractive surgery? If you have a choice, then probably with a minus 0.5, LASIK may be a little more accurate than PRK with a minus 0.5, such low refractive errors. But up to from 1 onwards, PRK and LASIK seem to be about the same accuracy.
True. In fact, Praveen, whenever we see any flap-related problem, either previous buttonhole, incomplete flap, or those kind of things, if you do go ahead with a surface ablations, works beautifully well.
Yeah, absolutely.
Yeah, and Darshana, can you mute everyone? Can you please mute everyone?
Yes, sir.
Yeah, good.
Looks like I put someone to sleep.
Yes, sir. So we'll go to the next question. Next question is from Dr. Amandeep. She wants to know what is the minimum pachymetry would you consider before going to PRK, advising PRK?
For LASIK, the cutoff that we use is 500 microns, and anybody below that we do PRK. The lower limit that we use for pachymetry is 470 microns for PRK. Nowadays we are sort of becoming a little more rigid, and even in patients up to 510 microns, we are using PRK as first choice over LASIK, especially if the patient is female. I honestly should declare that I look for a reason to do PRK rather than LASIK, so I'm a little biased. Maybe you do not need to be that careful, but from my perspective, it probably is a bit of a risk for the future. So why even have that risk? So earlier, I used to have a tough time convincing patients where there's no indication to do PRK, to undergo PRK, but then you'll see that most of your refractive patients come to you by word of mouth. And now even patients who are suitable for LASIK, they say, no, I don't want LASIK. My friend got PRK, so I want PRK. So it seems to be getting a little popular.
And Pravin, just extension of this question, what is the residual bed thickness that you aim for in PRK? I think that's what he wanted to ask.
Residual bed thickness is 300 microns, 300 microns, not less than 300 microns in PRK.
And that is
the total
300 microns when epithelium has been removed, you've taken into account that, right?
Yes, at the end of surgery, 300 microns is what you want to leave behind at least. So also another question is how much would you ablate? So the total ablation that we do on the cornea is not more than 140 microns. I tend to limit my total ablation to 140 based on the refractive error in the optic zone. So modulate both to get ablation within 140 microns.
Do you like to see some percentage of your total cornea also that you would like to ablate? So it's, or 140. So suppose the patient has 500 odd microns. Do you want to limit to 10%, 15%, something like that in your mind?
No, I think that is more relevant for LASIK. For PRK, we don't use that calculation at all.
Okay.
Thank you, sir. We have next question from Dr. Anju Bajaj. She wants to know if a patient is having both myopia and nystagmus, which is the refractive surgery of choice for you?
Myopia well, if you have myopia, myopia and nystagmus, there are a couple of things that you could do. One is you could still do PRK where you can do a peribulbar block and then do surgery for the patient. But the problem is a lot of the lasers will work based on centration on the pupil. So that might dilate the pupil, so that might be a bit of a problem. The other method is if you have a microkeratome, you can apply suction at the limbus and then hold the microkeratome steady so that the nystagmus is neutralized and then do your treatment on the cornea as well. So you can circumvent nystagmus in that way. Between PRK and LASIK, there's nothing to choose. You can do either PRK or LASIK for somebody who has nystagmus. It really does not matter.
Thanks, sir.
Thank you, sir. Dr. Anju, would you like to ask something else?
Okay, thank you.
Okay, thank you, sir. We'll go to next question. Next question is from Dr. Nupur Rana. She wants to know whether you start topical steroids after PRK. What is your regime after PRK?
Yeah, so nowadays we start topical steroids on table. So the first drop goes into the eye on table, and then we start treatment immediately post-op. My regime is to use a very low potency steroid like loteprednol. My personal choice is loteprednol because I've seen that the chances of IOP rise are probably the least with loteprednol. Start them on 4 times a day on the first day of surgery. Then again taper 4, 3, 2, and 1. And then I keep them on steroids for a really long time. If my refractive error of the patient is more than 6 diopters, then I'll continue loteprednol twice a day for at least 3 months. And then after that, once a day for another 3 months. So total of 6 months on topical steroids. If refractive error is less than 6 diopters, Then usually at the end of 1 month, I'll take a call if I want to continue 1 time a day or 2 times a day, looking at the Haze. Typically, if I'm at 1 time a day, I'll stop at the end of 3 months. If I'm 2 times a day, then I follow the same protocol as for somebody with more than 6 diopters. Typically, antibiotics till the BCL is there on the eye and epithelial defect heals, and artificial tears, whatever you like. Earlier, the protocol was different. We used to use an NSAID on the eye, but then we stopped doing that because we find that there is a risk of corneal melt if you actually use NSAIDs in an eye that has an epithelial defect. And that's the reason why we stopped using NSAIDs, though they seem to give some amount of pain relief as well.
Praveen, in case you see some regression in early postoperative period, do you want to titrate your steroids? Do you want to increase or decrease based on the tentative refractory error or residual error or regression that you're getting?
In general, most of the changes in the refractive error in the early post-op period, especially in the first 3 months, seem to be because of changes in the epithelial healing. So sometimes you'll get a cylindrical correction, sometimes myopia, sometimes hyperopia as well. Most of the times you can correlate that to the thickness of the epithelium. So if there is regression or early regression beyond that, then I will typically, you're right, maintain them on a slightly higher dose of steroids than I would normally do, maybe 1 drop extra.
Any time that you would like to replace it with the prednisolone?
Hardly ever. I've almost never done that. Almost never used prednisolone.
Okay.
Thank you, sir. Next question is from Dr. Varun Baveja. He wants to know the concept of combining C3R with PRK. He wants to know it in brief again.
Yeah, so combining PRK with cross-linking is only for a very limited number of cases. And these again are patients who have keratoconus whom you're doing cross-linking for. So in case I'm doing cross-linking for somebody who has keratoconus and I also want to reduce the amount of refractive error, my goal is not to correct their entire refractive error, but to reduce it by a certain amount. The reason why we tend to do this is sometimes people may not be contact lens tolerant, may not be contact lens compliant. So you want to get them at least to spectacle best corrected visual acuity that is acceptable. So the cutoff that we use is somebody who has a thickness of at least 450 microns preoperatively. Then we remove the epithelium and then we do a PRK, which is limited to 50 microns. So maximum ablation is 50 microns. Whatever refractive error you can correct in that is what you will get. Once that is done, then we do cross-linking at the same sitting for the patient. And once that is done, then no more refractive surgery for that patient because you will have reduced the thickness to less than 400 microns. And if the patient requires a repeat treatment, you will not have adequate thickness later on. The biggest advantage of this is the fact that the quantum of cylinder tends to go down. So I usually focus on trying to reduce the cylindrical error rather than the spherical error, because even cross-linking has some effect of reducing the myopia. So I don't want these patients to go onto the hyperopic side. So I usually focus on reducing the astigmatism, and that seems to work quite well for this group of patients. Now the corollary is, if you are doing this as a PRK, can you do cross-linking after that? Now these are two different things. We are only using this treatment for somebody who has progressive keratoconus for whom you're doing cross-linking. In that case, you're adding on PRK as a treatment. But doing PRK alone for somebody who probably has keratoconus is not justified. And doing cross-linking again after that is not justified because this is not a refractive surgical procedure. You're only doing an add-on with cross-linking to reduce the quantum of the refractive error the patient has.
Okay. Sir, I also wanted to know that a lot of surgeons that I know, what they do is that if there's a borderline case whom they think that probably he'll go on to develop ectasia, they generally combine it with a C3R. So I would like to have your views on that.
Well, we've never done that. And that is probably more for your satisfaction than anything else. There is no proof anywhere that you will find that cross-linking as an add-on after PRK or after LASIK or after SMILE, though a lot of people report their results saying that it works well, there is no proof that it is protective against ectasia. You'll know maybe 10 years later. And to really get proof that it is protective, you'll have to do a case series with about 10,000 patients in each arm, which is impossible, which will never happen. And so you will never know what the truth is. The other downside is cross-linking by itself, long-term, even Theo Seiler says this, can result in some hyperopic shift of your refractive power of the eye. So if you have a patient where you think they're a borderline or you're hesitant to do surgery, don't do surgery. Instead, just put them on contact lenses or give them glasses. But instead of not doing, avoiding surgery, doing a PRK or a LASIK and then doing cross-linking, I think is not justified.
Right, sir. Right. Thank you so much, sir.
I think Pravin, what he's discussing about is a procedure called flash LASIK. There's something called as flash refractive surgery. Okay, Darshana, you can go ahead with the next question.
Yes, sir. Next question is from Dr. Rajan Gupta. He wants to know what you do about reducing the post-operative pain for the patients.
Well, for one, don't give them your phone number. Otherwise, they'll bug you for 3 days. Well, so you can give the phone number of your emergency or your fellow who can talk to the patient. But then again, seriously, the amount of pain is not a lot. There are a certain subset of people who have a lot more pain. And for those patients, what we do right now is you put a Diclofenac skin patch, a sustained release skin patch that will release the drug over 24 hours. So it comes in a packet of 3. So I get the patient to buy it, change it every 24 hours, and by 3 days, they're usually very comfortable. You can give them oral analgesics as well, but because of the problems with gastritis and all of those things, they're hesitant to take medicine. So I don't do that for people who I think are very sensitive. This works for 99% of the people.
Yesterday, Dr. Mukesh was discussing about the use of AccuVeil soaked contact lenses. He used to soak in Diclofenac, that AccuVeil is available. Used to soak for 10 minutes and then use to reduce the post-operative pain. Does it work, sir?
Personally, I have no experience with doing that. But then theoretically, the reason why I do not use an NSAID like AccuVeil, which is Ketorolac or Diclofenac, is because there are several publications that show that these can predispose to corneal melt when exposed to a cornea that does not have epithelium that is intact. So I believe that a couple of days pain is probably something that you can pay for the guarantee that you will not have a corneal melt in these patients.
Pravin, I have that experience. We have used this AccuVeil soaked contact lens for quite some time now. And we found that there is definitely improvement in the pain part. But as you rightly said that then AccuVeil was not available, then we shifted to GABA-Star, this gabapentin thing for a couple of days, and we found was pain relief was equal. So now we don't even look for that whether the AccuVeil is available or not. We use gabapentin for patients who we feel are quite sensitive. Otherwise, as you rightly said, it's better to tell them that it's more of counseling. If you tell them that, this pain is good, it's good for you because it means that it's healing. So if you somehow counsel them well, they take it up.
Yeah.
Thank you, sir. Next question is from Dr. Simi. She wants to know whether you prefer Mitomycin C in all your PRK cases.
Well, for a significant period of time, we use Mitomycin C in every case. So the calculation that I use is 10 seconds of Mitomycin C exposure per diopter that is corrected. So if you have a patient who has -4, you use 40 seconds of Mitomycin C. If you have somebody who has 7 diopters, 70 seconds of Mitomycin C. Nowadays, since about 2 years or so, more on an experimental basis, I've stopped using Mitomycin C for people who have myopia less than 2 diopters. So anybody who has more than 2 diopters, I always use Mitomycin C, but anybody less than 2, I've stopped using.
Okay, sir. Thank you. We have next question from Dr. Gunjan. She wants to know the role of timolol in post-PRK regression.
Well, that's an interesting question because there are a few publications that actually show that timolol works well in post-PRK as well as post-LASIK regression. Personally, I have used it quite a bit in patients who have regression, and I don't think it is something that you can reliably say works in 100% of cases, but in a large majority of cases, it seems to show that there is a reduction in the regression that has happened after surgery. Interestingly, the effect goes off after you stop the timolol, so I tend to keep patients on timolol for extended periods of time. But it also is a practical solution, because a patient comes to you 6 months after surgery, they have about -0.5 or -0.75 and say, Dr. Saab, what is this? I have myopia. What do? You can either start lubricants, which you know is not going to work, or you can start timolol to buy yourself some time and say you use timolol and come back 6 months later. And 6 months later, I would say about 70% of the time it works. In the 30% of the patients, I'll say continue using timolol, and hopefully the patient will lose interest in coming back and seeing you.
Okay, sir. Thank you. We have next question from Dr. Yuvika. She is asking whether you prefer PRK over LASIK in most of your cases.
Well, to tell you the truth, that is right. If given a choice, I would do PRK in the majority of cases over LASIK. But then if there are cases where there is absolutely no indication for doing PRK, and I also would like the patient to have earlier recovery of vision, then I do LASIK in those patients. But you're right, given a choice, for me, PRK probably would be my go-to procedure.
Okay, sir. Thank you, sir. We have taken up most of the questions. Thank you so much.
I think the last slide of yours have told everything. That was, I think, the final nail in the coffin. So I'm sure that after this talk, so people will think about PRK from a different perspective. So then Pravin has covered everything so well and patiently answered all the questions. I would like to thank everyone. So this class is almost full. We have a capacity of 100 and we were more than 90 in this class. It was really good. Thank you so much, Pravin, for giving your time, sharing your expertise. It is always a privilege. It's whenever I listen to your talk, whether it was 10 years back and it's now, it's always pleasurable. And thank you so much for your time.
Hey, thanks a lot, Vikas, and thank you everyone for the opportunity. Like I said earlier, this is the only stimulating part of the lockdown period. So it is as much a pleasure for me as it might be for you. So thank you again for the opportunity.
Yeah, thanks so much. Thank you, Darshana, and everybody in the team LJ for taking care of all background work. Thank you so much. Bye-bye, everyone.
Thank you so much, sir. Thank you so much.
Thank you. Take care.
Bye.
Bye.